Hi, welcome to this presentation. Today I'm going to present to you the bone health outcomes from a clinical trial, RESOAR trial. Let's start introducing this disease they are investigating. Osteoporosis is a silent disease. Bone tissue can deteriorate gradually until a fracture happens. One main type of this disease is postmenopausal osteoporosis. Postmenopausal osteoporosis affects women due to the loss of estrogen, which normally suppresses osteoclast activity and promotes osteoclast apoptosis. Its efficiency therefore accelerates bone resorption and leads to loss of bone mass. Hypoxia is another contributor to bone aging. It has been shown to upregulate osteoclast activity and inhibit osteoblast function. This process could relate to the decrease of blood supply to blood tissue with aging. Now I'm going to introduce you this supplement they are proposing called Resveratrol. For simplicity of pronunciation, please allow me to pronounce it res. This is a cytoestrogen which can signal through estrogen receptors. Preclinical work has been shown that res can inhibit bone resorption and supports bone formation. But human data before the RESHAL trial typically is typically short with less than 6 months and often include obese or diabetic patients, and results shown by the studies are modest, creating a gap for a long, well-controlled trial targeting postmenopausal women. This paper asks two practical questions. Does long-term rest improve bone mineral density and bone turnover biomarkers in estrogen-deficient postmenopausal women? And are bone effects related to vascular improvement and given the rest is known benefits on microcirculation? Now let's introduce you to the study design. The RESOAR trial was a 24-month randomized, double-blinded, placebo-controlled crossover study. About 122 postmenopausal women aged 45 to 85 years old was recruited. Each participant received rest for 75 milligrams twice daily or a placebo for 12 months, and they were switched to the other side over to an alternative treatment for another 12 months. It is important to highlight that the RESOAR trial was not designed purely for investigating bone health. It was a broad investigation into rest as a supplementary for healthy aging, with outcomes across cognition, vascular function, meta metabolic health, mood, and bone. The article we are focusing today reports the bone-related outcomes, specifically bone mineral density biomarkers for bone turnover. Before I go into the results, I would like to briefly explain how these bone health was measured in this study. The main measure is bone mineral density or BMD. This tells us how much mineral is packed into the section of the bone. High BMD means a denser and stronger bones that is less likely to fracture, while lower BMD means weaker bones, high fragility, and greater risk of osteoporosis. This DSX result is expressed as T-score. The T-score compares someone's bone density to healthy young adults at peak bone mass. The more negative T-score, the weaker the bone is. The study also measures biomarkers of bone turnover in blood. The first was CTX, which is a collagen fragment released when osteoclast breaks down bone. So a higher CTX means more bone resorption is occurring. The second was osteocalcin, a protein produced by osteoblasts during bone formation. Higher osteocalcin generally reflects more bone building activity. Together, these biomarkers give us a snapshot of the balance between bone breakdown and bone formation. Now let's talk about the results from the study. After the first 12 months of supplementation, rest has no effect on whole body bone density. This is not surprising because it's so broad. But we can look closer at specific sites. These sites are critical when diagnosing in the diagnostic of osteoporosis. We see modest yet clinical meaningful benefits at the lumbar spine. Bone mineral density increased by about 1.3% and T-score improved by 1.5% compared to the placebo group. Gains were seen at the femoral neck and the hip too. Looking at the biomarkers, there was a trend towards lowering the CTX, suggesting reduced bone breakdown, but osteocalcin remained unchanged. Overall, the 12-month parallel analysis suggests rest has helped slow down the bone resorption and supports bone strength at clinically relevant sites, even though its effect on whole body BMD was negligible. In the crossover analysis after the 24 months, rest once again improved lumbar spine and femoral neck BMD and T-scores, confirming what we see in the parallel phase, which only after 12 months. This time, CTX was significantly lower, reinforcing the anti-resorptive effect. However, osteocalcin and the whole body BMD stays unchanged, same as the parallel phase. Importantly, women with higher CTX and osteocalcin benefited the most, showing a larger reduction in CTX and osteocalcin. Looking at a population comparison, after 12 months of supplementation, the rate of decline in femoral neck BMD was just only 0.34% compared to the expected 0.96% per year in elderly women in New South Wales. At the lumbar spine, women on rest showed a 0.46% increase in BMD from the baseline, whereas the reference population loses about 0.04% per year. Now, these effects are modest compared to pharmacological agents, drugs, which can rise spine BMD by more than 13% over 2 years, but the key point is that the benefit of rest was seen even in healthy women with normal bone density, not just those with osteoporosis. The crossover analysis also revealed the carryover effect. Spine BMD stayed higher even after 12 months of restorol, suggesting some degree of durability of the supplementation. That said, we still don't know if these modest gains are enough to prevent future vertebral fractures in otherwise healthy women. The author suggested a possible mechanism through three main points. First, rest has an estrogen-like effect. Rest can induce osteoprotein, which blocks the signaling pathway and reduces osteoclast activity. That matches what we saw in the trial, with lower CTX level indicating less bone resorption. Second, in aging bone, marrow stem cells tend to make more fat cells instead of bone-forming osteoblasts. Rest seems to tip this balance back towards the osteoblasts, help to preserve bone structure. Third, rest improves vasculature function. Poor blood flow and hypoxia in bone accelerates breakdown and inhibit formation by enhancing vasodilation, as demonstrated in the RESORT trial by another study. Rest may reduce hypoxia-related bone loss. So overall, these complementary actions provides a biological explanation for the modest but consistent improvement seen at the spine at femoral neck. There are several strengths to highlight in the study. First, the trial design is very robust, with randomized, double-blinded, and placebo control. Importantly, it's crossover, which means that every participant acts as its own control, reducing variability. Second, duration was unusually long for a nutritional study, running for up to 2 years. That is important because bone density doesn't change at a sudden point, and short trials often miss meaningful effects. Third, adherence rates were high. Capsule adherence was around 95%, showing a good treatment group. Finally, the biomarker trends were consistent and coherent. We saw modest increase in BMD at spine and hip, and a reduction in CTX, suggesting less bone resorption and improved vascular function. All of this align with what has been seen in preclinical studies. Of course, this study also has several limitations. First, the bone outcomes were secondary endpoints. The trial was not originally powered to detect difference in bone density or fracture risk. Second, the effect size is small, increase around 1 to 1.5% in BMD at the femoral neck. The reported 0.34% showing slowing of bone loses is very close to the DXA precision error rate of 0.4%, which makes the clinical significance debatable. The author tried to strengthen their case by comparing the data against a study from 1989, the durable cohort in Australia, but since DXA technology and analytical methods has advanced since then, that comparison adds uncertainty. Another limitation comes from the crossover study design. Without a washout period, because women receive both treatment in sequence, any residual benefit from rest may have carried over into the placebo phase. This makes it harder to separate the treatment from carryover effects, and these issues become more important given the small effect size detected in this trial. The trial also tested only one dose of rest, only the fixed dose of 75 milligrams twice daily, so we don't know the optimal dose for bone. Finally, these objects are relatively healthy postmenopausal women, so we cannot assume these same effect will happen in men or patients with established osteoporosis. On the other hand, this is also a strength of the study because postmenopausal women are estrogen deficient, making them an ideal group to test rest as a estrogen-like action and its potential as a preventative measure. So what does this study add to the field? First, it provides the first long-term clinical evidence that rest can slow age-related bone loss in postmenopausal women. That's a big step forward compared with earlier short-term studies. Second, it helped to bridge the gap between preclinical mechanism to human outcomes. We know from animal and cell work that rest acts through estrogen-like signaling. And in this clinical trial, we see modest BMD gain and drop in CTX and improving microvascular function that all fits in this biological story. Third, this highlights the vascular bone connection. The study showed that women who had better vascular improvement also had better bone outcomes, reinforcing the importance of blood flow of bone health. And finally, rest is not acting as a drug to treat osteoporosis. It is a preventative supplement, something that could help to slow down bone loss before fracture occurs. Looking ahead, there are a few clear directions for future research. First, we need a larger trial that are designed to look at fracture directly, not just bone density. Second, we should test different doses of rest because only one dose was used in the study. Third, it would be useful to study the combinations such as rest with calcium and vitamin D, or even together with a standard osteoporosis drug. We also need more mechanistic study in human to confirm how it works and to test rest in high-risk groups like women with osteoporosis, men, and in different ethnic populations. Finally, longer follow-up is important to see if modest bone density gain we saw actually lead to fewer fractures over time. That is the end of my presentation. Thank you so much for listening.